Thank you and welcome to the subcommittee meeting on House Bill 368. I'm calling this meeting to order. Sorry, 378. I apologize. I'm not trying to jump the gun for next Friday, I promise. This is the 378 subcommittee. This is the bill that is titled An Act Requiring a Healthcare Provider to Inform and Offer to Take and Preserve Blood and Urine Samples from a Patient who may have been drugged or sexually assaulted. When we met earlier in the spring, we had a lot of discussion around this, and there was a lot of concern about the idea of who would be included. On a closer review of the actual language, as opposed to the intent that I know, which is so that if somebody has been attempted to be sexually assaulted, they know their rights. I've seen that when you look at the actual bill on line 6, it says if a patient asserts that they may have been drugged. It does not say drugged for the purpose of sexual assault. Sexually assaulted, or then going from line 6 to 7, subject to an attempted assault. That was always intended to say, or subject to an attempted sexual assault, or drugged for the purposes of furthering a sexual assault. So there was a huge amount of confusion around that by some people who had read this bill and came in not knowing the intent behind. And they thought that this was going to massively increase the scope and then put rape kits to use in areas where there was not sexual assault involved. I truly believe that's probably why this whole bill was derailed, because all that this bill is doing is putting again into statute rights that already exist, but are unfortunately not well known. There's a copy of the statutes. I believe everybody has one, but if you look to 21M18, it's one of the stacks of those. I can give you mine where I put all of the sexual assault, the third page of the one that is in front of you. Yes. So if you, on the third page, just above, from just the second line from the bottom, it says the right to be informed of the rights under this section. Some of those rights, if you look up a little further, number 3, B3, it says that you have the right to be informed in writing of policies governing the collection and preservation of a sexual assault evidence collection kit. So you have the right to be informed. The question is, how are you informed? And I think that that's really the crux of this issue. If you look at page 4, which is section 21-M19. Yes. Oh, if you do the microphone, since we are recorded and broadcasting.
I'm still not on the page.
Okay,
Oh, this
that
thing.
stack right there.
Okay. Which stack? Okay.
Of the, yes, the third and fourth page is the statute. So first we were looking at the third page of the statute, right towards the bottom, the second to last line, D.
What's the number?
The third page is M:18. 21-M18. And so on line D, it says the right to be informed of the rights under this section. And then if you look up higher under B3, it says the right to be informed in writing of policies governing the collection and preservation of a sexual assault evidence collection kit. At the point of care, that notification depends a lot on the training and knowledge of those providers. So I'll move you to page 4, which is 21-M19, the notification of sexual assault survivors' rights. This is where the Attorney General, in Roman 1, the Attorney General shall provide written notice regarding sexual assault survivors' rights in RSA 21-M18 to medical centers, hospitals, forensic examiners, sexual assault service providers, state and local law enforcement agencies, any other state agency or department reasonably likely to serve sexual assault survivors, and shall make the information set forth in RSA 21-M18 publicly available on the Attorney General's website. Now I will take you to the excerpt that I've provided you, and that you were provided a different excerpt at the hearing. This is, I had given it to you right underneath the one that has some proposed language with notes that give you a breadcrumb trail. This is it's right underneath
It's
the
this
one
thing.
right there. Yes. This is 16 pages of a 124-page document that I was only able to find on the Attorney General's website by Googling for the name of it. It is available, but it's hard to find for providers and especially for survivors of sexual assault. Going through, there's a lot of rights that are established, and it's amazing the amount of work that went into this. We heard from SANE counselors at the initial hearing about how much work they have done and how carefully they have worked this process. The 124 pages is the result of that, as well as another 100+ page document that pretty much has checklists and basically flight takeoff lists for every single provider who will interact with people. There's nothing like that for the survivor. That's something that I think is actually quite critical because I'd say because sexual assault is so common, it's so isolating, and you don't know where to turn, and your world's just been turned upside down. Yes?
So what you just said is this is the document for the hospitals, the doctor's offices, then or whatever. And what you just said is that there's not a similar kind of document about what to do if you're the victim or the survivor?
Very close. This is 16 pages of the 124-page
Well,
document.
okay.
But yes, yes.
But I just wanted to be clear
Yes.
of what you said. Okay, thank you.
Yes, their rights are outlined here. Your rights as a survivor are outlined here. I spent 6 hours reading through it, and there were parts I only skimmed. So it's dense. When you're informed of your rights, it's important to actually be able to understand it. And there was also some misunderstanding among people who are highly involved in sexual assault and sexual assault survivor care at the hearing. There was confusion about whether sexual assault requires penetration. I have the criminal code of all of the sexual assault. We have aggravated felonious sexual assault, which is what people typically think of as rape. We have felonious sexual assault, which is what's generally considered statutory rape. And then we have misdemeanor sexual assault. That is basically, it would be rape, except it was not penetrative. So you may have grabbed somebody, you may have been trying to rape them, but you were only able to get a hold of them or try to get a hold of them. So that is against the law, and that actually is in all the information provided by the coalition on the Attorney General's website. But it takes a little work to find it. So that's Representative Cushman.
Just a thought that might be helpful too. Even on the felonious sexual assault, it doesn't require penetration if it's if there's a power
Oh, yes, the power-
relationship, and yeah. So there's a couple of if it's a minor, there's a couple of other variables that even without penetration, it could still be the highest degree of a charge.
Thank you. Thank you. Yes, this is very, very complex. I appreciate that clarification. Yes, it's that the aggravated felonious sexual assault is RSA 632-A:2. And perhaps the most important part, going back down this breadcrumb trail on the laws, is in the definitions for the sexual assault and related offenses. It's the criminal code. I'm not sure if we have this copy of the criminal code. So I will pass this out. We'll pass those two over. I'll pass these two over. I know I'm killing trees, but I want to make sure that we're protecting survivors. So this has those statutes for the aggravated felonious, and misdemeanor. And at the top is the definitions, and I bolded Roman 4, which is the definition of sexual contact. That means the intentional touching, whether directly through clothing or otherwise, of the victim or actor's sexual or intimate parts, including emissions, tongue, anus, breasts, and buttocks. Sexual contact only includes that aforementioned conduct which can be reasonably construed as being for the purpose of sexual arousal or gratification or the humiliation of the person being touched. So that is what the standard is in the misdemeanor. There's all the different permutations, but just going down to the basics. We're just looking to those. So trying to deal with this misunderstanding, trying to deal with this lack of information. I've been looking at this, and I think that probably the best way to move forward is to give a specific list of rights that need to be enumerated to survivors that's including but not limited to. And as we move forward with this, actually like to see what the prime sponsor, Ellen Reed, has to provide input for us here.
So is this
Representative Weber.
two-page thing, this is your proposal?
Both Representative Leon and I worked on that proposal together, and I can explain it a little bit more. I did want to also, as I guess I should say Madam Chair of the subcommittee, had been going through the definitions of sexual assault, which is 632A2, 3, and 4. Under 632A2, item lettered F is the specific statute that makes drugging for the purposes of sexual assault also fall under the definition of sexual assault. So I just wanted to outline that. So as Representative Leon, or I should say Madam Chair, has spelled out, and I'm sorry I'm having difficulty talking, you probably know this personally impacts me. We have in law the absolute unequivocal right for victims to have a kit, to be informed of their rights. It's so much work has been into this. We put this into law, and then we went one step further and said the AG's office has to then send out instructions in the form of 2 over 100-page documents, in addition to the survivor's rights, which is that third page, 18. And all of that has to be sent to every medical provider and law enforcement officer. We went through all of this. We even expanded those rights to make sure it covered deceased people, right? People who had already passed away, even though they had had a sexual assault. But we did not close the gap, because while all the providers and law enforcement officers, but I'm speaking primarily of providers, have to be informed by the AG's office, there is nothing making those providers inform the patients, the victims, of their rights. And since there's nothing holding their feet to the fire to inform their patients, that means that there's no reason for them to actually read that AG's guidance that is by law has to be sent to them. So I'm just looking to close the loop. We said we have these rights, even to the point that the state has said we will pay for your medical exam, your visit to the ER. If you don't have insurance, the state will pay. And it's even if you are deceased. And we have these rights in law, and the AG's office by law has to send out the notification, but we didn't close the loop because I think at the time that we wrote this, we added this to law, we just presumed, of course, a doctor will inform their patients of their rights. Of course, a law enforcement officer will inform a victim of their rights. But that has, not just in my case, but also in Linda Rule, who's the victim advocate at the AG's office, told me twice over 2 separate phone calls that this is a pandemic of doctors who do not understand what constitutes sexual assault. They're not lawyers. They don't understand. Because we colloquially call it a rape kit, they think there has to be penetration. And because they think that, they don't understand that they can submit any separate element of that state collection kit individually, that you don't have to have a swab, a vaginal swab, in order to have urine tests for drugging, et cetera, et cetera. So I'm just looking to close the loop. We said that they have the rights. We told the AG's office that they have to inform all the providers of those rights. And now we need to make sure the providers, who are the ones in contact with the victims, inform the victims of their rights, and that's all. And I'm sorry for maybe waxing philosophic right there, but so I have told Representative Leon that she is my hero for this issue, and she truly is, because she's put in so much work on this. So if I can ask you to look at the language that is titled amendment, it's just plain language. I did have an amendment drafted, but Representative Leon and I worked further on it. So this is not an official amendment yet. This is all going into 18, which is the survivors, basically the Sexual Assault Survivors Bill of Rights, M18. And there are 3 changes that we are proposing to make, and I have an additional comment on the back.
Yes, Representative Weber.
So is this in the same format that OLS usually gives us, so that the the matter that's in plain text is already a matter of law.
Yes.
And what you are proposing is just the only changes to existing law are the bolded and italicized bits.
That is correct, Representative
Thank you.
Weber. That this is, everything you see here is existing law with the exception of the bolded italicized pieces.
That relieves my mind considerably.
Yes,
Thank
indeed,
you.
indeed. And I'm sorry I didn't have it as an official amendment yet.
Yeah,
The three changes that I have here, under paragraph 1, again, existing language, it says, in addition to the rights of a crime victim, and it cites the Crime Victims' Bill of Rights, a sexual assault survivor shall have the following rights: the right to not be prevented from or charged for receiving a medical examination. That is already in law. That is already in law. What we are adding here is including any individual element or elements of a state sexual assault evidence collection kit.
and if I may pipe in right here, that is within the rights. It's just buried within the 124-page document.
Precisely. It is in policy and a document that I dare say very few doctors actually read.
Right, may I? Yeah, and I would say that probably one of the things that needs to happen is this needs to be a one-pager, because there's no doctor, I mean, probably no doctor who has time to read 124 pages on one thing, where what we're going to effectively do is, you know, or what happens in our ER, I'm not an ER provider, but what happens in our ER is that the ER provider will call the sane nurse who will do all of this.
Right.
And so what I'd want to do is just, I don't know if we want to add this to the bill, but I think the expectation that all the ER doctors in New Hampshire are going to read a 124-page document on this when they're trying to remember how to treat a dissecting aneurysm, and also just what their process in the ER should be for anyone who's coming in with a question of sexual assault. So we just somehow need to close that loop so that there's some simple thing where the physician isn't, you know, stuck in
Right.
this thing.
Having to be a lawyer.
You've just
Yeah.
had me, yes.
No,
We
and
don't-
that's exactly what we're trying to do here, is to make it this is what a doctor needs to do. This is what a doctor is responsible for knowing. And so, like I said, Representative Leon and I have worked, and I would say especially her at this stage, to simplify that. I do want to go back to your comment earlier about the SANE program. So one of these, and this is why I believe we experienced pushback on this bill, because I think it was, the perception is that this was somehow stepping on the toes of the SANE program, which it isn't, because indeed, in fact, it actually enhances that program, because was in my case, if a doctor doesn't understand what sexual assault is, the doctor won't call a SANE nurse. And no SANE nurse was called for me, even though I insisted on the state kit. So anyway, so the first piece is clarifying that, and it's actually in a later section of law that specifically says the state evidence collection kit, but we're just taking that from that section of law and duplicating it here as well, saying, and adding that it includes any individual element or elements. And then, as Representative Leon already said, there's these rights. Be aware of B3, which is to be informed in writing of the policies, because I'll circle back around to that in a second. The second change is paragraph 2, where we realized that sexual assault survivor was not actually defined anywhere in any of these RSAs. And there was confusion from even the supposed experts about what constituted sexual assault. And so we very clearly and specifically, it's a bit redundant for the doctors specifically, because the RSAs that cover sexual assault are RSA 632A2, 3, and 4. But here we spell it out in language here as well. So sexual assault survivor means any individual who asserts that they have been sexually assaulted or subjected to an attempted sexual assault, including non-penetrative assault, sexual assault. The administering of a drug or other intoxicating substance is part of an attempted sexual assault, and any offense. So actually those RSAs already cover the non-penetrative and cover the administering of an intoxicating substance, but we spelled that out there because we want the doctors to be able to understand immediately. And this is this 18, the whole section is the Sexual Assault Survivors Bill like rights. So I think what we foresee is this being a written one-pager that doctors then give to their patients. And then the final, and by the way, so there was a mention of the definition of sexual assault survivor, but only to say that it included a deceased victim, so someone who had passed away since their assault. So we obviously kept that in the definition, but we added the clarifying what that meant, referencing those RSAs that define sexual assault. And then the last change here is a new paragraph, which is the mandate to inform the victims. So if I can take you back to your little packet of existing law, the last page, which should be M19. Yes, ma'am.
You're going very quickly,
Oh,
and I
I've been
appreciate that,
told
but
I have that
need,
problem.
I need just a minute to read section 3 because there's a
Oh.
lot of stuff that's just
Oh,
been
no, I
handed
was
to us.
going to read it, but I wanted to, as context, point out 19 because it references 19.
If I may, Madam Chair, I learn with my eyes, not with my ears. So if you wouldn't mind just giving me a moment to read it, then I would love
I
to listen to your
apologize.
explanation. I just, for my own benefit, I will, thank you.
We'll take that pause to accommodate everybody's processes.
It's a lot to digest and it's a lot of pieces of paper. And
Right.
I just need to read for a minute if. Thank you.
Okay,
You're welcome.
so
Appreciate it.
I apologize for going quickly. The new paragraph simply says a healthcare provider, law enforcement officer, or other employee of an entity listed in RSA 21M19, which was what I was asking people to turn to, who in the course of their professional responsibilities has contact with a sexual assault survivor shall provide the individual with written notice of their rights under this section, which is the Sexual Assault Survivors Bill of Rights, and RSA 21M19. And I'm going to underline this piece and of the policies governing the collection and preservation because that goes back to B3 and that's what the notes on the back are. But I wanted to point out that 19, the RSA that this references, is the law that says the AG's office has to send out that big 124-page document of which you have a few pages. It's that law that says the AG's office has to send that out. And it enumerates who it has to send out that information to. So it says, the Attorney General shall provide written notice regarding sexual assault survivors' rights, which is 18, to medical centers, hospitals, sexual assault service providers, state and local law enforcement agencies, and any other state agency or department that reasonably likely to serve as sexual assault survivors. So that's where the AG's office is telling all the professionals what those rights are. But there's nothing saying that those professionals now have to tell the victims what their rights are. So we are referencing this list of entities and saying that list of entities now has to transmit those rights to the victim. Where I underlined the last piece, so now we're saying that this list of entities has to tell the victims of their rights under the Sexual Assault Survivors Bill of Rights. In addition, there's extra rights under 19 under paragraph Roman numeral 2. And of the policies governing, which goes back to B3. And if now you want to turn over the page.
Actually, if I could pause you for just
Yeah.
one moment. As we're working through this, especially with the input of Representative Palmer, I think we perhaps should actually look at requiring a form to be produced and having that go through the rules process that includes these rights we're going to discuss, and that form needs to be provided by the providers because my thought there is that then the provider sees it as they're providing it and so does the patient. Representative Weber?
I'm just wondering whether that needs to happen in that format. I mean, my understanding, and Representative Palmer can correct me if this doesn't happen, is that any medical care provider's professional organization will be updating them as a matter of course, as they do anytime the statutes change. And is that not a more effective way of communicating changes in the law rather than requiring a form, which is then another lot of verbiage for somebody who's really busy to not read? I know and I'm just going back to my time as an attorney, when there were changes in the law, we got memos from the Bar Association that said, you should be aware of A, B, C, D, E. And I don't know whether that's an appropriate way of dealing with it, or whether you two feel that an actual form needs to be created either in statute or in rules. I'm trying to keep this as simple as possible, because the more complexity we add, the more things there are to run aground on.
Indeed.
And the basic intent is clear, so.
So Representative Palmer, then Cushman, then Nattaratham.
So, yeah, I think that I think the testimony that we heard from the ER people, aside from any of the other concerns, were just that if this becomes too cumbersome, there are people in the waiting room who are sick. This has to be something that they can have work quickly. What Representative Weber said is true, is that we get, and it's mostly through the hospital. For me, I work in the hospital, so then when there are rule changes and things, we get notified. We have regular meetings, we get notified. What I'm wondering is that this is a little bit in the same kind of thing as if someone comes in and you expect child abuse or elder abuse, we're mandated to report it, but it's not a huge amount of paperwork for us. We report, then the legal people, the people who do that, take over. And that's what I think needs to happen here, is we need to be able to get this, absolutely make sure that the victim is informed of all of this, but have it work in a way that is not going to be so cumbersome that because that could work against you. I mean, like in a really borderline case, if I'm the ER provider and I'm really busy, I could sort of go, I don't think this is really what's going on, as opposed to, oh, this is category, this is where we need to go, this is who I need to inform. Now I just can focus on the medical aspects of this, and other people will take over with the legal and all of that kind of stuff. So, and I'm not.
Representative Cushman?
Thank you, Madam Chair. Yeah, I'm not sure. I feel like just printing these two statutes, 18 and 19, and having them available. I mean, we have the Patient Bill of Rights statute available at all the healthcare facilities. It's posted and then it's available for review. So I'm not sure that a form would be necessary. It might be just if we want to really like boil it down to, but this is pretty straightforward also, but I'm also used to reading legalese, so.
Representative Nattaratham, and then Representative Weber.
I think I'm good, it got covered.
I think that Representative Palmer's point is met by the definition in 2, which says any individual who asserts they have been sexually assaulted or subjected to attempted sexual assault, including non-penetrative, the administering of a drug or other intoxicating substance as part of an attempted sexual assault, or the offenses, and maybe you write something out about that. But the language as I read it leaves the patient in control of what they say and what they assert. And as soon as they have asserted something, just as in the case of child abuse, then you have triggered everything else. And that makes it, I think, I don't know if it's acceptable or not, and I'm really sort of unhappy that a lot of people aren't here to listen to this discussion who work in the field. But it seems to me that that is not an unreasonable ask of an emergency room physician who's trying to deal with stuff very quickly. If the patient says, this happened, or I think this happened, then that triggers a report, and that takes, and then the doc goes on treating or dealing with the protocol. So I think that in many ways gets rid of some of the issues. I think clarifying offenses under 632A2, A3, and A4 might be helpful for people, but so that people see that in words rather than as a statutory reference. But I think for me, that kind of gets us out of the form business and into the quick treatment business and into a quick referral to the people who are then trained to deal with the issues. And so that's just my comment on it.
That's very helpful. This has been a helpful conversation. My thought was you could hand somebody a pamphlet, but you don't want to sit in the waiting room with a pamphlet. Better to have something that looks like legalese. Representative Reed?
So much of what I had to say has been touched on, but I'll just do my best to connect it. And the patient's existing patient bill of rights was brought up, and that's exactly what I was thinking. It's a one-pager. It's available at every healthcare facility. Representative Weber is exactly right that this is the trigger. If someone says that they were assaulted or someone attempted to assault them, sexually assault them, then that's what triggers the doctor having to inform them. And between this Sexual Assault Survivor Bill of Rights and the additional rights in 19, which I'm not sure why they are not included in the Sexual Assault Survivors Bill of Rights, but there are additional rights, and some of them are duplicative. That literally would fit easily on a single piece of paper. So I think Representative Leon and I both had the vision that there would be a pamphlet that if you said that you were sexually assaulted, the doctor then, or a nurse or whoever, gives it to you. And if you want to cover yourself, perhaps gets a signature for saying that they had received it. But that's it. I just want to clarify, because you mentioned mandatory reporting. It's actually... You can't do that you can't report it against their wishes. That would be illegal. So that's not mandatory reporting, it's mandatory informing of their rights. But I understand what you're saying. There's certain things that doctors are required to do beyond simple medical care. Not that medical care is simple.
Thank you.
Yeah,
Yes, Representative Palmer.
so I see your point, and what I was thinking of is, as somebody working, you know, I am required to do something here. In the case of the child abuse, I'm required to report it. In this case, what I would be required to do is ask the patient, and if they say, yes, I want to pursue this, then I need to trigger that.
So that's separate. That's a separate. Whether or not they prosecute is
No, I'm sorry. What I meant is whether the patient, if what I'm required to do as a physician in the ER is I see this patient who looks like they may have been assaulted, is I inform them that they have rights to this, and if they want to pursue it, then what I would like to see is that then what I do as a physician is I trigger the whole process, the same process, and then I'm documented that I've done this, and then if we have information to give the patient about exactly what their rights are, that we do that too. But I don't have to do that as a physician. I just have to trigger all of that happening, because I don't have time to be the one who prints off the document and do all of that stuff.
So actually, if I may go to the guidance that's in there, the guidance actually says that when it's reported, it needs to be treated as a medical emergency, and as soon as possible, the patient should be escorted to a private location in the hospital, and the hospital shall immediately call an advocate from the local crisis center to meet with the patient, and the patient is allowed to meet privately with them so that nothing ends up in the medical record. This was my notes coming from section... let's see, that's the conversation. 1, 2, 3, that's the third one. That would be on page 9, I believe, in here. I did not quite cross-reference correctly. I'll give you, it's from the attorney, yes.
I just trying to sort out what's in statute and what is advisory opinion.
Yes, thank you. Yes, I have a breadcrumb trail for everything that is within the guidance, which was created through statute. So I don't believe it went, I didn't see it in the rulemaking process, but I believe his guidance has quite a bit of heft, even if it's not statute. Representative Berry.
To respond to Representative Palmer, the way you said it sounded a little backwards to me. So the way I see it, and I'm happy to engage in this conversation, is if someone says that they were sexually assaulted, the first thing you do as a physician or a nurse or whoever, and I presume you would have these printed out already, pamphlets ready to go for anyone saying that they were sexually assaulted, and you tell them, here are your rights. And then they realize they have the option to say, have a state kit, and then they can pursue that. And yes, it also triggers calling an advocate or sane nurse and all of those other things, but that, as far as the first line of defense, you have to let them know what their rights are.
And then I'll let you answer that. In reference, we have my copy of the Attorney General's, it's page 9, which is actually top of the second page, has the emergency response.
I'm not questioning the law or any of that. And as I'm remembering back in the day when I used to work in the ER, is that there was one of our really good ER nurses was a sane nurse, and basically we just, I would just go, Gene, what do I do? Okay, so that was really helpful. But I've a little bit lost the thread because I don't work in the ER. But the reason I said it the way I said it was the wording that you have in this, which is that from a patient who may have been drugged or sexually assaulted. So what I wasn't saying that I wasn't discounting the idea that the patient might say, I think I was drugged for the purpose of, but that I might suspect it, even though the patient's not saying anything, and then bring it up. Now, if that's not your intent, that's fine. But this sort of leaves it in the realm of, I was thinking of it the way I think of like elder abuse, which is what I see, which is that the patient may not be complaining of that, but you suspect it. And so at that point, you bring it up. And so I completely get your idea. If the patient says, this guy tried to do whatever, that should trigger it. But should it, I guess my question to you is, should it be triggered if I just suspect that, but the patient's not saying anything because they're afraid to or whatever?
So that actually is within the guidance and guidelines as well, which is critical, because there actually is a discussion about the elder abuse issue. Because if you have attempted sexual assault on a vulnerable person, whether they're elderly or otherwise vulnerable, that does escalate it as well. And I think that your procedure of notifying Jean, the sane nurse, actually was exactly what the process is.
So what I would say is, what this is saying is where the notification of rights is absolutely required. There's nothing preventing a physician who thinks that someone may have been sexually assaulted to be like, by the way, in case you were sexually assaulted, here are your rights. You don't have to report it to law enforcement. You don't have to make that decision. You can collect evidence right now. So you can, as a physician, out of your own wisdom, decide to go beyond just the minimum requirement of, this person said that they were a victim, I have to inform them, and go, maybe they are a victim, I better inform them anyway. There's nothing stopping you, and any good doctor, I think, would do that. But this is just the legal trigger for when you absolutely have to.
Could I have you run through that list of rights that we think probably should be enumerated so the patients can know?
I'm very happy to. So Representative Leon did the hard work of going through the 124 pages and kind of boiling down the most essential of those rights that are in the AG's guidance. So these are additional rights in the AG's guidance that are not in statute. That is the back of the suggested wording. And so what she was suggesting, and I understand it's a lot of extra language, but I would wholeheartedly support adding the codification of these rights that are currently just in the AG guidance. So this would be added under, on the suggested language, would be added under 3, to be informed of, in writing, of policies governing the collection and preservation of a sexual assault evidence collection kit, including but not limited to the following: A, the sexual assault does not only include penetration. B, most sexual assault cases of patients over the age of 18 are not required to be reported to police, and in these circumstances, evidence can be collected anonymously if the survivor is unsure about reporting to the assault to police. C, that sexual assault exams are conducted in hospitals and by sexual assault nurse examiners if available at that hospital, and a sexual assault is to be treated by the hospital as a medical emergency. D, that as soon as possible, the patient should be escorted to a private location in the hospital, and the hospital shall immediately call an advocate from the local crisis center to meet with the patient, and the patient can meet privately with the advocate for confidential conversation. E, that blood and/or urine is only collected if it is suspected that drugs were used to enable a sexual assault within the prior 120 hours, that the survivor's consent is required for each portion of the exam, including to return control of their body to the survivor. F, that evidence of a sexual assault inside or outside New Hampshire can be collected in New Hampshire, which is really important. It impacted my situation. And G, that while evidence can be collected days after a sexual assault, the sooner it is collected, the better. And once again, I appreciate the work that Representative Leon has done to take out the most essential elements of that 124 pages. I do think we should include those. I understand that it's adding a lot of language from AG's guidance and codifying it, but I think it would be good to include those. And I still think that all of that, plus what we have in statute already, still fits on a one-pager.
Representative Weber?
And have I correctly understood that, where is it? That E means that the patient gets to say, yes, I want this done, or no, I don't want this done. And if they say, no, I don't want this done, providing that they're over 18, that controls. I assume if we're under 18, we're looking at abuse mandated reporting in any case. Okay, thank you.
Yes, that's, go
Yes,
ahead.
that is correct, and that's within the guidance. I know we were
Right.
told about all the work that went into this, and I think that this process honors that work.
No, and
sorry,
I will, if I may just add, I mean, it sounds to me that what is being done here is following the lines of what's currently done rather than creating a new scheme. So I am much relieved over when I looked at it initially and thought, oh God, this is a whole new thing. It's taking bits and pieces of what already exists and making them clearer, so.
I would actually clarify that a little bit. It's what should be done, but unfortunately, it's not always done. So by
All laws are
clarifying-
what should be done. But,
Yes. Yes.
And I apologize for scaring anyone with my initial bill because it always was meant to codify what already should be happening, but very, very frequently is not. And it's not just in my situation, but from the AG victim advocate's own wording.
Yes, Representative Palmer.
Yeah, and my point was pretty much that what some of the objection I heard initially was that it was going to just create this huge extra amount of work instead of it just being a relatively seamless thing that is now just not what we ought to do, but what we are required to do. But it's now, as I said, it would work sort of the same way as I said, is once you've heard from the patient, you have to get this thing going, but it's going to be the same process that we used before, pretty much.
For any medical facility that's doing the correct thing according to the AG's guidelines already, yes, completely no change. For any medical facility or provider that is not following AG's guidance, then they're going to have to start doing that.
And may I, one more follow-up? This is a really practical question. The private location within the hospital, I mean, I've worked both times in very small little hospitals. You're talking about, it could be just a single room in the ER. Just as long as it's not in a room where there are three people in beds lying next to each other, I'm assuming.
That's from the AG's guidance, and I'm sure Representative Leon can speak to it, but I think it was always meant to be as private as
You could manage.
practicable, yeah.
The only one that requires going into a truly private room is if the victim wants to speak with the advocate separately, because that is entirely confidential and not subject to the record-keeping requirements of HIPAA, as it should be, as they're referred to the rights. I mean, it probably could be a closet if necessary, because if you need privacy, you don't necessarily need a patient treatment area for that discussion.
So that would be the same kind of thing as anybody who's being counseled, or that, where it's not just medical treatment, it's, they're,
The consultation area.
yeah.
And there's one area in E that may, as you read through it again later, may feel that it may be some flowery, superfluous language. It's the end talking about the survivor's consent is required for each portion of the exam, including to return control of the body to the survivor. The reason why I added that language is because that's within the guidelines. You have the right to refuse. Somebody has just been victimized, and the fact that they've refused a certain part of the test doesn't mean that there wasn't actually evidence. And by spelling that out, hopefully that will prevent overly aggressive defense attorneys saying that, no, the victim didn't want that because she knew that this hadn't happened. We don't want to impugn the person simply because she did not want to have a swab of one of her areas where it was not involved. It's not required. And as a lawyer, I'd love your input on that, Representative Weber.
Anybody who knew me as a lawyer knew that criminal procedure was absolutely out of my bailiwick. But it did bring me another question, which is, I understand E up to the point of the comma is required for each portion of the exam, but I don't think I understand the plain English meaning of including to return control of their body to the survivor, because I don't understand the meaning of when control of their, I mean, I understand lack of control issues that go along with both sexual assault and medical treatment, but I guess I'm not understanding what those words are intended to do.
Thank you. Actually, my intention is so that it's clear that somebody has that right to do that. They're there specifically because control of their body was removed through this assault or attempted assault. And the informed consent of each part has more than just our individual choices, but also the fact that you're trying to reclaim some autonomy after an attack. It's not worded well, and I would
No, it
appreciate
isn't.
some language. I was too
I
late
would
to add
put
more
a
copy.
period after exam, because the point is that the survivor's consent is required for each portion. So if the survivor says, I want these samples taken, but I don't want these samples taken, that should be their decision. And that is, in fact, returning control of their body to them, because they are being treated in ways they say they want to be treated, as opposed to how they're told they're going to be treated. But I think, and I will speak as a lawyer, although I'm not a lawyer and I cannot practice in this state because I'm retired. I think that last language, while it does express the intent of this whole thing, which is to return control to somebody who has been subjected to external controls, I think it doesn't help in terms of saying what we're going to do. So I would just line that part out if that was acceptable to other people, and put a period after exam. And that is the operative phrase that allows the patient to determine what they desire to have happen.
I do think that there are some of the legal issues around it as well that probably will need to come back next year. In the AG's guidance, it does say there was some of the concern and pushback was that by informing people of the ability to take the drug or urine test, there may be some people that because of either prescriptions that they're on or their own choices, whether for legal drugs like alcohol or their recreational choices because they decided to do cocaine that day, that is not an excuse or a reason for them to be sexually assaulted. And that's within the prosecution guidelines, that nobody is to be charged if they are positive for recreational drugs or drug misuse. I think that it actually would be very important for us to come back probably to clarify that denial of some of these tests is not grounds for saying that somebody is trying to lie to the one, but that's not something to handle here. That's a bill that we probably, hopefully we can all commit to working on, assuming we're all here again next session, to bring that to criminal justice to help close that loop. But I think that this bill, even without that line that I couldn't word quite well, I think moves us quite forward. I guess at this point, I'm curious if anybody has any more input, any concerns. Representative McDonald, we haven't heard from you yet.
Well, in a room full of doctors and lawyers, former lawyers and medical professionals, there wasn't a lot for me to add. I do have a question, and it's been touched on. The initial hearing on the bill, the New Hampshire Association Against Domestic Sexual Violence testified against this bill. Does anyone have any insight as to why that was the case?
I actually went and I looked through their website to see what information they provided. I was quite concerned when they testified, when they said that somebody who hadn't been penetrated did not need to have a rape kit. So I looked at their guidance, and what they said in response to that question was inconsistent with the guidance from the coalition. So if you look at their actual guidance and what they provide to patients, it says that penetration does not need to occur for a sexual assault. So unfortunately, we got incorrect information in that hearing about the policies and the use
So
of
the
those
person may have
kits.
misspoken or misunderstood the bill, perhaps?
Yes, it may have been related to them thinking that because the attempted assault did not say attempted sexual assault, that may have been what the issue was, because they may have thought that this was hitting somebody over the head, and they were equating it there. Representative Palmer?
And to what you were just saying, some of that may have been that they were worried that it would be, and when we started this, we were talking about the wording here that may have been misleading. And I think some of the testimony might have been going for that, where it's just like somebody might walk in, they were at a bar and they got a drink and they felt funny afterwards, but there was no question of assault, but they just want to go to the ER and get tested to see if they got drugged. And they were worried that that would tie up a whole ER room and lead to a whole lot of problems. So if that first line is corrected, that takes away that problem, because it's just pertaining to drugged for sexual assault.
Yes, if you look at the language given to us that Representative Reed and I worked on, we also changed the title of the bill because that title the previous one reflected the wrong information. This would change it to an act expanding the information provided to survivors of sexual assault regarding their existing rights.
And then just as a note, I came into that initial hearing in the spring with an amendment changing that initial title because the title was always incorrect. The title implied that the doctor would be storing the evidence, and that never happens. It's the police. So it was just an incorrectly worded title from the get-go. But yes, what the bill has always been intended to do and what it does now with this language is simply expands the information that is provided to survivors about their existing rights.
Representative Weber?
And I'm just looking at a communication from the coalition that again speaks to the bill is not consistent with current practices and protocols. And it sounds to me, not knowing precisely what those are, that the bill is now far better and far more clearly aligned with current protocols and has a better descriptive title as well. So unless I hear otherwise from somebody who isn't here or isn't available, and I don't know the person who came in, so I don't know if they have any comments or whether you as chair or we as a committee want to hear them, but I'm seeing a head shaking no. I am much more comfortable with this formulation, so.
My thought with this is, especially because we don't have any of the other stakeholders here, perhaps we should see if anybody wants to send us information to the subcommittee through this next Friday. We can notice a subcommittee meeting even with only 24 hours notice. And there is past history of subcommittees meeting 15 minutes after the conclusion of a House session, which we do have scheduled next Thursday. My thought would be that we see if this is actually consistent, because I believe we were following the requests of those stakeholders who expressed concerns, get their feedback. Assuming that there's agreement on this, I will get this language drafted up into an amendment that we can circulate, and then we can notice to come back and discuss that. I can notice things separately if we end up having a much bigger issue, because I would rather us deal with this. I think that we've actually reached a fantastic point on this bill, and we're honoring the actual intent, as opposed to the way it was just tucked in with an extra addition in the statutes. Representative
So
Weber.
I think in terms of procedure, the next important thing is to get this drafted, and my concern is I don't know when it gets widely available and up on a website. It's usually not up on the website until somebody's offered it.
Correct.
So my concern is how do we make sure, I mean, in terms of notice, anybody who wanted to comment or know what was going on with this should be here, and maybe they're watching at home, and that's fine, and that's their right. I just want to be sure that we can make the language available, so, and presumably anybody who's watching could contact you and have the language provided to them,
I will have this
which is the
drafted.
important thing.
I will have this drafted, and then anybody who's watching at home or watching later, contact me. I will send you the language. And then we would like to have this information, I guess, no later than Monday. That gives people to look at it over the weekend, the end of Monday, so we can
Thank you.
make sure that we're moving forward the correct way. And I think that, and I need to know specifically where this deviates from the guidelines, because all of this language is coming directly from the statutes and from the guidelines which govern this. So I would need to have any objections be quite specific to see if there's any issues.
I think that would be very helpful, because it also helps with drafting if something is,
Yes, I will put together
Unaligned.
our proto drafting. If we weren't in the middle of bill drafting season, where everybody is still trying to get their language back on their LSRs, it would be a lot easier to keep popping these different ones through OLS. But I want to make sure that we have this information, we make it available to people, but also we're not overtaxing OLS, because I think that if they had had a little bit more time to work on this bill in the first place, we would have dealt with this and passed this bill last fall, quite honestly, if we had gotten to this information at that point. That might be presumptive.
that's not their job.
No, it's not. But when you send the request, it's a matter of, do you stick it in at the end?
Sure.
Or are you responding very quickly and we're all working through the quick process? Because I remember last year, there were some bills we had to sign off on before we even had the final text, because we were dealing with people who were out with COVID, out with maternity leaves, and dealing with the fact that we're the
Sure.
we're the third largest
No, I
English-speaking
understand all of
language
that.
legislature with the smallest OLS. So I'm glad we are all able to work together as a team, the legislature, OLS, and everybody else as well. So, does anybody else have any reservations about our path forward?
Question. This is a question. So, as Representative Weber said, I'm way more comfortable because my main concern was having something that was just too cumbersome to work well. And as long as we can make something that works well, that'll be great. Because I think the intent, I don't disagree with the intent at all. It was just how to make it work so that it works properly and smoothly for everybody. So my question is, we passed the bill, and so somebody now has to sort of make the rules. And I'm a little vague on how that happens.
Thank you. I am,
You're going to be monitoring us, right?
yes.
Monitoring teleconference.
So one of the challenges and one of the reasons why it's perhaps better we don't have a form is that form would have to go through JLCAR, the Joint Legislative Committee on Administrative Rules. I have the honor of reading through 300 pages of rules every month to vote on. So that will go through the process. It'll provide the information that is available. I'm not sure that this actually falls under rulemaking.
I
You
don't think it does.
you simply would need to, there's the information where it directs the AG to give the information to everybody who's one of the providers. So because this was the 124-page guidance and the other complementary guidance with the action steps wasn't through rulemaking, they can take this information and have it in a form that hopefully is available far more prominently on the Attorney General's website. For child crimes and for other crimes, they're very close to the top of what's available on the Attorney General's website. And I would encourage them that, assuming that we do pass this and we move forward, that this information about the sexual assault survivors' rights is prominent because sexual assault's an epidemic.
The other thing is that if we don't have to go through the rulemaking process, the information will be available to patients months and months earlier. And I think that all of us would be more comfortable with that.
Oh, I'm sorry.
Representative Cushman?
Sure, I just want to speak to how I envision it to happen in, say, an ED. You know, you just, once it passes, they literally print out 18 and 19 and staple it together or have it front and back and it goes in a filing cabinet. And then a patient comes in who says, I've been sexually assaulted, or I think I was drugged, someone was trying to harm me sexually. And they say, oh, and they tell the nurse, please get her the patient rights. And delegation is included under this, you know what I mean? Anything that you can delegate doesn't need to be stated explicitly so. So they just say, make sure you get that patient, that form or that statute, that paper that's in the file, and then they give it, and then they go from there.
If I can, that's precisely what I was imagining as well. It's the parts that have had to be dealt with administratively have already been dealt with administratively. That's why we have 124 pages. But literally just as far as, how it's actually enacted, every individual hospital or provider would just have whatever their print off is. They could format it however they like and just pass it out when someone says they were assaulted.
Thank you. So as we look through all of this, the subcommittee doesn't need to take actual action on our amendment. So we'll solicit information from other stakeholders through the end of the day next Monday, the 23rd. And we'll see, depending on that input that we get. I assume that I'm not expecting much pushback. If that's the case, then we probably are able to move forward to this and bring it to executive session. If we have need for another work session, I'll contact all of you and we'll figure out whether it's a short one immediately following session, or if we have one that we schedule separately.
Fair
Does
enough.
that process work for everybody?
Yep.
Fantastic. And with that, I thank you all and I call this work session to a close. Thank you.
Thank you. Yep.